Hey everyone, welcome back to Static Cardiology here on EMTV. I'll be giving you an ECG rhythm and a scenario. On the bottom of the screen you'll see a timer for 1 minute and 30 seconds. This time closely resembles the average amount of time you'll want to be spending on each card during an actual National Registry exam. When the time is up, we'll go over the rhythm and I'll give you my treatment. Enjoy the card and good luck.
3, 2, 1.
I hope this rhythm didn't throw you off too much. Let's go ahead and take a look at it in a little closer detail. Now the first thing I like to do with any rhythm is count the rate. I'm counting 5 R waves here, which would make this rate 50 BPM. The next thing I'll look for is the presence of P waves. There are some P waves here in the usual places that we would look. However, there are additional P waves that you may not have seen right away. Next thing I'll do is check the consistency of my R to R interval. My R to R interval looks fairly consistent. Based on the fact that I have some extra P waves here, I know that this is some sort of AV block. I'm going to take out my trusty ruler and see if my P waves are lining up. So as you can see, there's a distinct P to P interval that is completely separate from the R to R interval, meaning that there is an atrial ventricular dissociation occurring here. Because of this, I'm going to diagnose my rhythm as a 3rd degree AV block, or a complete heart block. Now, let's go ahead and take a look at the scenario. You were dispatched to a local hardware store for a 45-year-old male complaining of chest pain and a near syncopal episode. He appears pale and diaphoretic and reports feeling as if he was going to pass out after standing up too quickly. He reports his chest pain began this morning after waking up, and he describes it as a mild pressure in the center of his chest that does not radiate and is not reproducible. He is alert and oriented, denies trauma, and reports dyspnea only on exertion. Physical exam reveals clear lung sounds bilaterally, no peripheral edema, and a slow, weak radial pulse. He denies any pertinent past medical history, but reports that he recently tested positive for COVID-19. Your partner obtains the following vital signs: blood pressure 81/33, pulse 50, respirations 21, SpO2 91% on room air, and a blood sugar of 85. You attach the monitor and see the rhythm above. although the recent positive test for COVID-19 may seem irrelevant to the scenario, it is actually perfectly relevant. COVID-19 related myocarditis is well known, at least among patients suffering from the original variants of COVID-19. There have even been some reports of COVID-19 myocarditis causing complete heart block. So this may not be an uncommon field finding. Now, back to static cardiology. In order to be successful in static cardiology, not only must you diagnose the rhythm correctly, but you must provide appropriate treatment. So determining whether or not this patient is stable or unstable is paramount if you want to deliver the correct treatment algorithm. For instability criteria, I use the acronym CHAD, and this of course stands for cardiac insufficiency, hypotension, alteration in mental status, and dyspnea. This patient meets several of the CHAD criteria. He's hypotensive, dyspneic, and had a near syncopal episode. Because of this, my final diagnosis for static cardiology is going to be an unstable third-degree AV block. Now, let's go ahead and move on to the treatment. Just like with all my other cards, I'll begin treatment by regurgitating the mantra, Scene Safe, BSI, IV O2 monitor. The next thing I'll do is I'll administer atropine, 1 milligram IV push, given every 5 minutes up to a total of 3 milligrams. Now, although atropine doesn't routinely work in high-degree heart blocks, it's still recommended that you start with this intervention. And be aware that atropine has to be delivered rapidly in order to avoid a paradoxical bradycardia that will occur if you push this medication too slowly. But because my patient is unstable, and unstable gets the cables, more definitive treatment of this patient is going to involve transcutaneous pacing. Because this can be a painful procedure, I'll first consider sedation, using an appropriate sedative or analgesic, and then I'll attach the pads and turn on the pacer. I'll then set my rate anywhere between 60 and 100 pulses per minute, or ppm, and then I'll increase my milliamperage or current until I see a pacer spike immediately preceding a QRS complex. This is what's known as electrical capture. I'll then feel for a carotid pulse, and this will be mechanical capture. For pre-hospital EMS, it's then recommended to increase the milliamperage approximately 5 to 10 more to allow for slight patient movement during transport. For additional blood pressure control and management, I'll then consider the administration of IV fluids, and if needed, vasopressors. And finally, rapid transport. And that's it. If you enjoyed this card, please make sure to head over to my channel for more. And while you're there, make sure you like and subscribe, and check out my other playlists, like Static Pharmacology. I'd like to thank you again for continuing to support my channel, and if there's something you'd like to see in the channel in the future, send me an email or leave me a comment. Until I see you next time, stay safe, keep washing your hands, and have a good rest of your night.